and I'm also the director of the Care Economy Research Institute, and also the co-lead of the Geriatric Oncology. It's an MRFF ReViTALISE project initiative. So before we start, I would like to acknowledge the traditional custodian of the land that we are meeting today. I'm at the moment at the Albury-Wodonga Regional Cancer Center in Albury in the Wiradjuri land, and I would like to pay respects to elders past and present, and also would like to extend my respect to any Aboriginal and Torres Strait Islander people that joining us tonight. So before we start, I would like to let you all know that we're going to record this presentation this evening. And we also, if you have any questions, please let us know in the chat. There is a chat function. It's roughly about the lower middle part of your screen. So feel free to add things in there. And also, if you don't mind putting your name and your role, like for example, if you are a geriatrician, or if you're a dietitian, or if you're a PhD student, that would be greatly appreciated. And there is a Q&A questions area that you can also add your questions there. So for the session this evening, I will chair this session, and I'm joined tonight by Associate Professor Christopher Steer, who is the co-lead of Geriatric Oncology. Christopher is the medical oncologist based at Border Medical Oncology. He's an associate professor at University of New South Wales. He's also an adjunct professor at La Trobe University. So joining us tonight is Professor William Dale. So William is the George Sy Family Chair in Geriatric Oncology. He's a professor and vice chair of academic affairs, director of the Center for Cancer and Aging, and also working at the Department of Supportive Care Medicine at the City of Hope in Duarte in California. William is a renowned geriatrician and also a board-certified palliative care physician. He has expertise in both geriatrics and palliative care medicine. His work focuses on advancing cancer care through innovative models and quality of life research. William has authored more than 200 publications. He received continuous NIH funding and was honored with the 2024 ESCO B.J. Kennedy Geriatric Oncology Award in recognition of his leadership in cancer and aging, supportive care medicine, cancer survivorship, and medical decision-making. So it is my pleasure and also Christopher, to host his visit here to Albury-Wodonga Regional Cancer Center. And tonight he's going to share his perspective about enhanced supportive care for older patients with cancer, a global perspective. And then, we will do a Q&A at the end of his presentation. So please feel free to add in the Q&A section or in the chat function if you have any questions, as he gives the presentation. Thank you. Over to you, William.
Great. Thank you, Irene, and thank you to Christopher for hosting me. It's a delight to be here at La Trobe and to talk with you a bit about my views on combining geriatric oncology or cancer and aging with supportive care medicine. And my perspective is always closest to my experience in the United States, but this is to be a little more global and hopefully lessons learned from where we are for all of you. Thank you for the lovely introduction. I don't really have any disclosures. I don't have any pertinent financial relationships outside of the academic grants that I have. I do admit to always liking older adults and like working with them and knowing them to learn from them, whether it's their experience, wisdom, equanimity or perspective. I've always enjoyed that. It's what's allowed me to pursue my work. This is a couple of my favorite patients. One on the left, a woman in her 90s, who I took care of, and the one on the right is a woman who I celebrated her 112th birthday with her here with a glass of champagne. So the global perspective to start with is simply that the world is getting older. By 2050, older adults will make up over 20% of our global population, and that will be about 1.5 billion people out of almost 8 billion people. It's happening somewhat differentially, so you can see the places where that 22% is going to exceed 30%, and other places where it's going to be somewhere between 10 and 30%. I'll show you in a minute where both the United States and Australia falls in that, both right now and in the future. So if you're talking about the United States, we're getting older as a country. Between 1990 and 2050, the largest growth we're going to see is in the oldest parts of the population. So you can see at the upper end here how those green bars, which represent people from 65 to over 85, they continue to make up more and more of the population compared with those who are in the younger age groups. And that has profound implications for us, particularly those in cancer care. This is a graphic I've shown a couple of times now, but really struck me when I learned about it. So the darker color is those who are under the age of 5 globally, and the lighter blue or aqua color is those over 65. And a few years ago, for the first time, those who are older than 65 are exceeding and will continue to exceed, and that gap will grow, those who are younger than 5. And that's, as far as we know, never been the case in human history. And you know, much of what impacts all of us is going to be a turn on this fact. In addition to the general aging of the population globally, cancer is a disease that is associated with getting older right now. How and why that's the case, we're still working out. But as you can see on this graph, as you move from left to right over time into the 2035 and 2040 range, the number of people who are older or who have cancer is going to grow, and it's going to grow the most in these older groups at the top of this chart. All right, so we're back here where that line, that black line is, and that's just going to continue to increase. And you can look at that, especially for the 75 to 85 plus groups. So given that that's the case, and for example, right now in the United States and in Australia, about 16 to 17% of the population is over 65 years old. So given this, we have to come up with a strategy that will address both the aging of the population and the growth of cancer diagnosis associated with aging in the population. And in order to do this, I've outlined 3 areas that I've focused on that I think are important for us to address. One is to move from assessments, and I'll talk about the assessments we use for older adults, but to take those assessments and turn them into effective interventions to address these impairments and to help us make decisions about their cancer care. Infrastructure is going to be needed, and Irene and Christopher and others here, I know, are working on creating the necessary infrastructure to support vulnerable older patients through scholarship, training, clinical policy, and general national and local policies for Cancer and Aging. And then even with all of this, we will need people who are knowledgeable, who will need training and education in the form of guidelines, expertise, and professional expertise to improve the care of older adults with cancer, and ultimately to feed that back into the interventions that are necessary for us to have. Just to take you a little bit through the journey I've gone through in the last few years, starting in 2018, related to this. In 2018, based on a bunch of the work done by Arthi Huria, who was mentioned as part of my title and someone I worked with for many years, a national panel of experts was convened that really put forth for the first time from the American Society for Clinical Oncology, ASCO, or the largest clinical organization of clinical oncologists, a set of guidelines in which it was said that a new standard of care for patients was to receive the geriatric assessment that Arthi had developed to measure vulnerabilities and identify aging-related impairments that aren't typically captured in oncology. And this has been quite influential. It's now almost 1,500 citations to this guideline. But what we learned from that, and I'll show a little bit of data, is that despite this being the new standard of care, since then, still today, less, 25% overall, and as low as, single digits for some domains are actually using the recommended guidelines to identify impairments for older adults. And that presents a real challenge for those of us who are developing interventions when the assessments are not really out there yet. So these were those original recommendations of completing the geriatric assessments, including the essential GA domains and information, conducting predictions or prognostications for someone who we might cure with cancer and whether their life expectancy aligned with the treatment of their cancer, and then enacting GA-guided targeted interventions, although at that point in 2018, we still did not have the intervention data. So to step back just for 1 second to remind us about what is a geriatric assessment, what is these multidisciplinary assessments, they include minimally these domains of functional status, comorbidities, medications or polypharmacy, nutrition, cognition, mental health, and social support. And the reason these domains have been identified is that they are all independently predicting outcomes that are relevant for older adults, such as independence, quality of life, and care goal choices. This just as a one reminder or one example of each of the domains would have specific validated tools that we can use to identify whether there are deficits or not in those domains. Without reading each of these, every domain has these kinds of tools, and incorporating these assessments into our overall approach is crucial to the agenda ahead of us from a cancer and aging perspective. What do we do with these tools? This is a very straightforward approach that is underlying most of the decision-making for older adults with cancer, which is that you have an older person. On the one hand, over on the left, this is a patient of mine who was diagnosed with ovarian cancer and was treated for it at nearly the age of 90. And this is her after treatment that included surgery, chemotherapy, and radiation therapy. And she had no deficits at the time of her diagnosis. We did do a screening GA that had no findings on it, and she was fit for full dose treatment, and she did well. Over on the right, my patient who was 112, who was quite frail, a complete geriatric assessment is appropriate. Screening GA is not. She is frail, and a palliative approach were she to be diagnosed with cancer is appropriate. And probably the most challenging are these people in the middle. This is a colleague of mine, Martha McClintock, a biological psychologist, who agreed to represent this group, who are older than 65, who probably appear about their stated age, but who need screening assessments with a geriatric assessment. And to categorize them into those who are more vulnerable, those who may be completely fit, or those who may be frail, so that we can make treatment choices along the lines the guidelines recommends. This is Arthi's central work for our field, which shows toxicities from grade 3 to 5, along with a risk score associated with the Cancer and Aging Research Group, or CARB's geriatric assessment. That risk score ranges from 0 to 19. And if you get a score that's in the 0 to 5 range, your risk of serious toxicities requiring hospitalization is quite low, 30%. If you're in this middle categories between 6 and 9, your chances of toxicity is around 50%. And if you have higher scores, your toxicity rates can rise as high as 90%. And this is information that can be incredibly important at the beginning of treatment when you're trying to decide what treatment choices to make. Now, the key is, now that we have these kinds of assessments, what do we do with them? And essentially attaching these assessments and the individual domains to actionable items is important. And those actions come through supportive care or palliative care, an approach that improves quality of life, that focuses on relief of suffering by means of early identification of pain, other symptoms, and other concerns that are all both physical, psychosocial, and spiritual in nature. One thing that we found when we interviewed people after the guidelines had come out is represented here from a paper with a number of individuals you can see here. The first thing I'll note is on these charts, which show percentages of use of different domains on the geriatric assessment, and along the bottom are those domains. If you look at the red bars, those are those who said they had no awareness of the guidelines from ASCO, and the blue bars represent those who were aware of the guidelines. And it broke about 50-50 in about over 1,000 people that we interviewed. And what you'll notice is that the blue bars across the board are higher than the red bars, suggesting that at least awareness of guidelines, and hopefully those who are actually reading the guidelines, are much more likely to conduct these assessments than those who are not aware of the guidelines. That's a good starting point, perhaps, for people to get information disseminated about what should be done. However, the clinical awareness was associated with a couple of areas that suggest ways to improve the uptake. You can see in certain domains like mood, while a quarter of, let's say, those who know the guidelines say they use them, but less than 10% of people who aren't do regular assessments of mood, like depression and anxiety. We ask them why. You can see on the lower chart, those red bars, there's 3 of them that go up quite high right there in the middle. And that's people who say they lack the training and knowledge, they're uncertain on how to use the tools, and that they lack awareness of the tools themselves. And then at the far left, you see those high blue bars, and again, some red bars, in which lack of time, lack of support also contribute to why it's not being used regularly. This is a similar study which essentially shows the same thing, that less than 20% of oncologists are aware of the tools. And this was in 2022, and that 60% didn't use geriatric assessment to inform treatment for older adults, and that they simply find them too difficult or expensive to apply. So we tried to figure out why was it that they weren't used, and based on what we've been told and our discussions with people, I've come up with this set of reasons. One is processes, that tools need to be simplified, so they need to be distilled down to their essentials, that you need people who have the training to use the tools, so that if we give them the tools, they actually know what to do with them, policies that are structured in ways that encourage the use of the tools and the follow-up actions, and payment systems that financially incentivize the right behaviors. So how do we go about that in practice? This is some summary of our GAIN study in which we did a randomized trial with over 600 people and looked at the geriatric assessments on the left with standardized tools and offered an action plan of what should be done based on the findings on the tools. That's on the right. And between the GAIN study and the associated GAP 70+ study published in 2021, we were able to decrease chemotherapy toxicity as the primary outcome from 10 to 20%, with no loss on survival, and a number of secondary outcomes that included decreased falls, increased advanced directive completions, and in an associated study called COACH, increased communications and increased patient and caregiver satisfaction. And these two studies were relatively definitive about the values of geriatric assessments. And we could talk about more both of these later. But one question about this is that these were both in academic settings. GAP 70, for example, although in community practices, was through the NCORE network funded by NCI. So it had a lot more resources than your usual community practice. So we and others have tried to work a way on how can we bring this out to patients where they exist. So this is a supportive care telehealth application in which we have community site in Antelope Valley that's about 60 miles from our main campus out in a very rural area. And they do geriatric assessments on sites, and both through patient-reported methods in the medical record, but also on-site assessments of physical performance and cognitive assessment. And then our nurse practitioner who stays in our Duarte campus does telehealth remote consultations using that assessment, and then discusses them with the patients and uses local resources to intervene. And based on this work, we've shown that this is very widely accepted, with no one saying that at 9 out of 10 patients, and in most cases 95%, say this was a good experience, that they enjoyed, and that they could do it easily. And we recruited 250 patients into this study and are now doing the follow-up work to show what the results are of bringing it out to the community, and have translated this to other settings, including the newly opened randomized trial in Brazil using the same approach. One thing that we can use these assessments for pretty widely are to make better decisions about our patients. This is a approach that we've adopted for our own considerations, which is to take our geriatric assessments, use them to calculate toxicity risks and life expectancy, consider them using this information, the overall benefits and risks for older adults, considering the vulnerabilities that they have, and then use that to weigh quality of life for the treatments versus the quality of life from treating the cancer itself, and incorporating the patient's values and preferences for outcomes, which most of the time emphasize, let's say, independence or independence of action over, for example, additional survival benefits. So it's a way to incorporate the assessments into these action plans. This is just a full representation about using geriatric assessment to choose your intervention strategies to reduce toxicities. And in every category on the far left, you can use the tools that have been provided, develop cutoffs, and set up a care model in which appropriate actions are taken. Let's say social activity is triggered on the geriatric assessment. You notice that they're interfering with their physical or emotional issues, and can do appropriate referrals based on resources, whether it's social works, use of occupational therapy, or other local options for pursuing care. And every area has this, which could be incorporated into the care model, whether it's through an electronic medical record or, let's say, a written care plan. So having done all of this, if you sort of move ahead in time down this timeline with the guidelines I mentioned in 2018 through the production of the randomized trials, including a number of other ones, and one done by Dr. Sue here in Australia that showed referrals to geriatricians could lead to higher quality of life and less hospitalizations. To the point of 2023, when we came out with new guidelines that were being recommended based on all the work in the randomized setting. So now we're here, and with those new studies and the new guidelines are being told this is essentially a new standard of care, and we need to get better at implementing this, but also to enroll more older adults in the existing trials so we can learn more about what's happening. This is a paper by Mina Cedric, who was at City of Hope but is now at UCLA, in which he reviewed the literature on what are known effective interventions that improve the likelihood of enrolling older adults in trials. And the truth was there was almost none of them. There was hardly any studies in which you could say, we know for certain based on the evidence of how to enroll older adults in trials. We have some ideas, but this is an area that needs much more work. Essentially, they concluded that the research infrastructure is going to have to be modified and improved so that older adults can be enrolled. It's a second bullet point, which is where they are. So we have to go out into the community settings, find ways to enroll people into the new infrastructure if we're really going to make headway on improving the evidence behind what we do. So instead of the standard approach, we need to find solutions that haven't been used to getting increased enrollment in the trials. So how do we overcome these barriers? We took on the approach of developing a practical and clinically focused geriatric assessment and try to make it widely available to oncology clinicians and their practices. So streamline and shorten those long tools that we used in the larger studies but still maintain that all domains are covered. Use patient-reported measures whenever possible to minimize the amount of assessments in the clinic time, because the need to have patients seen expeditiously and efficiently in clinic are still there. Have to engage with those who are actually practicing in the community, like here in Latrobe, so that they have the tools and the training necessary to use them. And then we wanted to leverage the Cancer and Aging Research Group, ASCO, and SIOD, the International Geriatric Oncology Group, to disseminate the results widely so that people would use the same agreed upon set of tools. And so with the new release of the guidelines in 2023, based on these primarily two studies in the US, along with others, we updated the guidelines through the use of the Cancer and Aging Research Group, patient partners or consumer partners called Scoreboard. We came up with the practical geriatric assessment, which really boiled down the lumbar assessments into the focused, shorter version, again, reviewed by the Measures Core infrastructure from CARG, an action chart that was specifically targeted to use those assessments, and then dissemination through ASCO's network of dissemination with videos, infographics, website, and the CARG. So this were the new assessments. I've tried to highlight what's the updated components of it, which is to use the assessments for prediction, interventions, and toxicity reductions. Now that we knew how to do that, include all the domains, especially nutrition, cognitive function, and comorbidities. One way to do this is to use the PGA as an option that we had developed. And then number 5, implement GA-guided targeted interventions, which really is the new standard of care. So this quickly is what the CARG, the new practical geriatric assessment looks like right now on our website. and has all the domains listed, and includes in addition the CARG toxicity tool, along with the PGA. We have an action chart that we posted that specifically builds from the trials into actions that can be taken based on the assessments. And as I sort of move towards the conclusion of my talk, we have to translate this into actual clinical care. At City of Hope, we've developed our OASIS program, which is older adults specialized interdisciplinary services, and taken 3 of our clinics, and they are now designated as age-friendly clinics based on the American Hospital Association commitments to the 3 or 4 W's, and the Aging Wellness Clinic run by our nurse practitioners is really an outpatient clinic focused on new treatments for toxicity avoidance in those starting chemotherapy. Our Aging and Blood Cancers program, which is older adults getting bone marrow transplantations or candidates for that. And then my own SoCare clinic, which is really focused on older, vulnerable individuals above 75 who need appropriately focused supportive care for their needs, with developing other clinics at City of Hope. I think this is the right approach, that we build standardized clinical flow models to apply our approach to taking care of older adults. This just to show you how international this has become. The GAIN study and the GAP70 study are at the top, but you have studies including in Australia with the Integrate study by Dr. Su, showing value, Canadian studies, French studies, Denmark, etc. This is a reminder about process, people, policies, and payments as tools for building into the infrastructure the necessary pieces to enroll people in trials and to learn as much as we can. And I'll wrap up with the Cancer and Aging Research Group started by Arthi Huria from City of Hope, one of our sort of founders who died in an accident in the end of 2018. And her goal at the time and the mission for CARG is to join researchers across the globe now in a collaborative effort of designing and implementing trials for improving older adult care. We welcome anyone who has the desire to do so into CARG. This was her dream, was to one day all older adults with cancer would receive personalized tailored care using evidence-based medicine and a multidisciplinary approach. I think we're getting closer than ever with the newest trials that were introduced at ASCO and that now have been moved into published opportunities. CARG is something that we oversee with people across the world, and has now 730 members. Twice a month, we get together on Tuesdays for people to join us. Those are US times, Pacific Coast, 11 a.m. for me in California, about 2 p.m. Eastern time. I know it's a little early in the morning in Australia, but we would welcome you all to join us. If you can't join those conversations, please go to the website, which is at mycarg.org, where we have a number of resources that can be used, including all of the things I've talked about so far. We have an infrastructure grant that really supports people across the board in our different cores, including measures, analytics, supportive care, health services research, along with a patient partner group called Scoreboard, our consumer partner group, and our buddy task force for mentorship, and a junior card for people that want to participate. It's been successful. People who have come to our infrastructure have been able to get quite a bit of grant money, over $30 million based on the construction of the infrastructure. And we have an inquiry form on the website for people that want to ask questions of our expert panels and our cores, which are done relatively quickly. We collaborate with others, including the International Geriatric Society, the iReach program, and the Circle program, both of which are funded by NIH. One is focused on equity, aging, cancer, and health, and one on implementation research. And we can direct you to those groups as well for additional support. And this is a new program called the Geriatric Oncology Treatment Optimization Program, funded by the Rising Tide Foundation, in which we're going to conduct 6 different randomized trials using the PGA as the centralized assessment tool, so that we will learn what works in the randomized setting in a number of different clinical scenarios, including the newest one with geriatric assessment guided interventions with supportive care support remotely in Brazil. This is what the infrastructure looks like, which we invite you to join us with. Includes the CARG infrastructure I mentioned, supported by NIA, and the clinical trials program supported by the Geriatric Oncology Treatment Optimization, along with our patient partner group called Scoreboard. We'll go through this. This is just the different people who are conducting those trials. There's our clinic. So here's CARG. Dr. Hurria's favorite proverb was, if you want to go fast, go alone. If you want to go far, go together. That's our mantra, and we encourage you all to join us in going together to the finish line. Thank you to all of our funders and to my colleagues in the Center for Cancer and Aging, shown there, the deputy directors, Bonnie Catharia, my senior manager, and my other colleagues. So thank you to all of them, and to all of you who I've met over time and who I invite to join us at the various events we all attend. Thank you very much.
Thank you so much, William. It is absolutely a team effort, and you're leading the way in the delivery of optimal care for our older adults with cancer. Now, there is the opportunity, I think, to engage in questions in the question and answer. I hope that it's open, and I hope people can communicate with us. I don't think the chat function is working for attendees, but I think the Q&A hopefully is. I would like to start, if we can, with some practical questions, William, at City of Hope. And I'd like to, at this point, say that my thoughts, of course, are with the people who faced the devastating fires at the City of Hope. I know the hospital was ready to be evacuated because of it, so thoughts are with you and the team members there. But practically speaking, what does supportive care look like at City of Hope, a comprehensive cancer centre for our older adults, when you tell me that there's just one geriatrician, I think yourself, possibly another? Is the supportive care framework embedded in the electronic medical record, and what does it look like for the standard older adult with cancer, even in the cancer centre? We've done all this research and hard work.
Yeah. Thanks, Christopher. It's true that, like many places, we don't have a lot of geriatricians. I'm a geriatrician. My colleague, Tiny Nika Phillips, is an oncologist and a geriatrician, and we have some people who are interested in the clinical care of older adults, 2 nurse practitioners, but it's not nearly enough to see all the patients. We do have a robust supportive care department with 35 providers of various kinds across palliative care, interventional pain, psychology, and psychiatry. And then a large group of 180 people who are across interdisciplinary specialties: social work, patient family education, volunteers. We have our research team. So we have a robust supportive care group. And right now, our older adults receive very good supportive care, and they're starting to get more formalized research-based assessments connected to that. And our current approach at City of Hope is to make it work through the electronic medical record that they would get, that practical geriatric assessment. They would sort of automatically be sent to the appropriate supportive care teams to be cared for. And the biggest challenge is if you have cognitive impairments, we don't have a big, we don't have a cognitive expert. You have to find outside support for those groups. We're a growing system, and we're having some growing pains from our growing system of now in our remote areas, they're getting this support, but we don't have supportive care beyond telemedicine extended out into those other clinics. We have a whole bunch of them. So it's still a work in progress clinically, but I think we're into the next phase of how do we actually put this in place. And thank you for the comments on the wildfires. We were lucky not to evacuate, but a number of people lost their homes, including Dr. Hurry's family lost their home in the fires. So it was the most direct.
Supreme sadness, agree. There are three related questions here, William. The first one from Philip is, for an effective multidisciplinary team, what would be the ideal versus practical composition? How long does a typical assessment take? And how do you screen patients who would most benefit from a PGA? And then further thanks from the talk, and I thought your thoughts on how we do get this implementation of the practical geriatric assessment into place using these streamlined tools.
Yeah, all really good. So regarding the effective multidisciplinary team, I had come up with this concept at some point called the minimum effective dose of supportive care necessary to actually deliver on some of the promise. Because I do think there's a threshold below which, a single practitioner at a place who's told you're going to get all of the supportive care referrals or all of the geriatric referrals is actually a net negative. They get overwhelmed, they can't see everybody, and it's really not an effective strategy. So I do think you need a champion of some kind, whether a physician or a nurse practitioner. You need social support, psychosocial support, at least in the form of a social worker or some equivalents, and then a resources coordinator who can help put together the pieces that you need. I think with that minimal core, you can start a clinic and sort of build on it effectively. And that, requires you to analyze your local circumstance. But that's my best guess at what's the smallest thing you need. The ideal is every domain that you have, if it's nutrition, that you have somewhere to send somebody for nutrition support. If you have pain, you have this pain specialist. Every domain in that you'd like to have an intervention and a practical way to do it. I don't know how realistic that is without a lot more resources at most places. How long does the assessment, the PGA, let's say, take? So our PGA is 80% patient reported. So it takes the patient some time to go into the patient portal and fill it out. But if it's done, it doesn't take any time from the clinic. They bring that assessment and we look at it. There is 2 assessments. We do the physical assessment, which is a gait speed test, and the cognitive assessment, a mini cog. They take about 5 minutes in clinic to do with somebody in clinic. And if I was to pick, the minimal things that you need to have, I try to hold steady that we boiled the PGA down as much as we could. We're trying not to make it any shorter than that because we need all those domains. I do think you need some assessment in each of those domains unless you can't take action on them. And I think, I've talked about this a little bit, Christopher, if you can't do a cognitive evaluation, it might be premature to do cognitive assessments that you can have done. That being said, most of the time we can talk about whatever we find. So they're useful for communication. PGA takes overall patient time around 10 minutes. If people are really impaired, it could take 15 minutes. So it's not too long, and it's pretty as comprehensive as we can make it. The question about what are the ongoing barriers to implementation? and is this just another thing for busy clinicians to do? I think the worst thing we can do is add more time for clinicians to have to do something that they don't have time for, which is why developing tools that others, patients, families, others in the clinic who typically collect information do this, and we've been successful with it. In terms of workarounds, those are the what I call workarounds, is put into the clinic flow everything that is gathering information so that a clinician could walk into a room and have it, my imagination I've come up with is, think about a clinician who has lab reports, right? They have it in front of them, either in the electronic medical record or they have a report, and they're like, oh, the patient's anemic, I need to do something. Oh, the patient has this. It would all be digested so that the essential conversations would be done by the clinician with the patients, and it wouldn't take any time. In fact, it would make their day better because they would have better, more informed, more robust conversations with people rather than something seen as negative for clinicians. So I'll stop there.
I've certainly found, interestingly, there's two arguments about the role of the G8 screening tool in this process. I found it's useful, but maybe not for the reasons that you would initially think. So the G8, as people know, is based on the mini nutritional assessment. It's scored out of 17, and the threshold, if you score less than 15, then it's been shown to be a representative impairment and correlates with survival. There are camps in the geriatric oncology community that suggest you should possibly, it's not necessary, but in our local setting, I found it useful as an introduction to the world of geriatric oncology. I found that it's been recommended by the state of Victoria, actually, that people above the age of 65 or 70 should have it done. And it gave clinicians a number. It gave them a number of which, they scored it. Okay, definitely you're under 15. Okay, that gives us permission to then refer you on for the enhanced supportive care, as we call it, and more focal geriatric assessment, or it gave them permission to not do that. But it generated the discussion, and I found it really useful for clinicians as part of this, what I call, change management process for this complex intervention that really we're in for. So there's this step. So I found the screening tool of the G8 useful in that I noticed that it's in the PGA, the practical geriatric assessment, embedded, and then it gives that real information about diet and nutrition that you lack and weight loss. But I've certainly found that as an approach at our centre that helped. Yeah. Others have asked, can you comment on then the next step of implementation, the role of a nurse navigator to assist patients overcoming the barriers that once you find out what's wrong with the patient or in the comprehensive geriatric assessment?
Yeah, I think navigators of various kinds is arguably should be part of care teams throughout. I mentioned resource coordination. I think the navigators, nurses, or even lay navigators are essential and could be incorporated into the care model. They're often having conversations with patients before they ever even come to us and can alert us that, hey, this is someone who, is having hearing impairment, or this person really seems to, have concerns about their memory. And so both before we even see them, I think they could help. And then once all of these, services are aligned, having a navigator would be crucial. We have them at City Hope. We have navigators for our most complex patients so that they actually get follow-up appropriately for all these. So I think it's a very good idea, and many navigators.
And the feedback we've had is that even the electronic assessment that we use, it just creates a framework for our care coordinators, nurse navigators, anyone who are really there who want to deliver this care.
Yeah.
It gives them a framework to ask the questions that matter, and permission, once again, to ask the questions that matter to the patient so that we can focus in on age-friendly, person-centered care and what matters most. So I find that my care coordinators here, the care coordinators here, have come back and said, we really appreciate this tool because it gives us this, as I say, this framework to ask the right questions and then deliver streamlined supportive care services.
Yeah.
I think the next question is somewhat challenging, isn't it? Let's talk about the costs and cost effectiveness of these models. How are you addressing that in your centre, William?
Yeah, I mean, we've successfully made the argument that supportive care is a loss leader, if you will, that, it costs money to invest in supportive care, but all the other services are enhanced, right? And so if you focus the appropriate resources on the more difficult patients, then the less difficult patients can move more quickly through the system. And so it's worth subsidizing, if you will, upfront the creation of supportive care services. And I don't know that that's a cost effectiveness argument, but the administrators are willing to support it. And that is enough for now for us to continue the services and be mission support. I do want to say there are people doing good cost effectiveness, work in our field, but it's still early on, and it looks like we probably don't save costs in a way that you can tell, but that the benefits we get are much higher. It's kind of the same situation we've discussed if survival doesn't change, but the quality of that survival is so much better, right? And so it's less about costs. The costs are similar, but the use of those costs to enhance independence and quality of life seems clearer. One little technical one to your question about your point about screening is the active debate is, should we do a two-step, a short screener, and then send people for full assessment when they fail a screener? Or should we just do the, say, PGA right up front on anybody, let's say, above a certain age? And the argument, it's not clear yet which one cost-effective wise works, because the two-step makes sense, except it's hard to do two steps when one step would work. And it turns out you lose a lot in the trying to get coordination across the two steps in some ways. Combined with the fact that, in our Antelope Valley study, high numbers, 70 to 80%, have things identified on something like a PGA. So screening is so positive all the time. It's just an extra step rather than just doing the, fuller assessment. Anyway, we haven't solved that exact issue on cost effectiveness, I don't think.
We use it as a tool for change management largely.
Yeah.
Is the PGA tool completed online? And if so, what are the barriers for older adults in the electronic area? Certainly from our setting here in Albury-Wodonga, our tool is online, and we recognise we need to be flexible, but not really a surprising number. A significant number of people just do it from home before they come in. We've got the information, and that's fine. You do need to do the cognitive assessment and the timed up and go in person, really, and that is useful. But patients do it electronically, and it's not the barrier that we seem to think. However, you need to be flexible, and some people just need help, about a third. And so that's certainly our experience, but that's okay. We get that information and we ask whether they need help and they deliver it. That's our findings here in Albury.
Yeah.
What's the findings with the electronic assessment in your centre?
Yeah. So we found when we did, especially the remote one, which I think is the most relevant one out at Antelope Valley, that we had almost the same as you. You said a third. We had a third in terms of what people filled out. A third of them would do it in the electronic medical record online. A third actually just wanted us to email it to them. So they would tell us, email it, and we'll fill it out and we'll send it back, and they would. And another third, we had to actually have some means in the clinic, either a tablet or a paper pencil for them to fill out. And so people would choose different modes for how they wanted to do it. Anyway, very similar, interestingly, to what you said about a third, and same for us.
Yeah, we've got 300 patients, that's the data. But the role of the nurse practitioner is the final question we have here. There's another one snuck in. Nurse practitioner is vital, I would have thought. What's the, Jane Phillips asks questions about better understanding the role of that in your clinic and their value add.
Nurse
practitioners.
Oh yeah, nurse practitioners. So we have two outstanding nurse practitioners. I'd say that they are more important than doctors, honestly. I mean, I'm pretty good at what I do, but I'm not in clinic nearly as much as they are. They have regular contact. They spend the time necessary to walk people through all of it. I honestly, I think the ratio of like geriatrician to nurse practitioners, if you just want to talk in some general terms, should be like 3-to-1 or 4-to-1 or something, in terms of value add.
Yeah.
And there are a few things I think that our physician training helps the situation, but nurse practitioners are fundamental.
Instrumental part of the team.
Yeah.
Philip asks finally about specifically, is the PGA useful for a pilot program with older patients and with hematological conditions? I know you've argued that you're setting up the PGA in a number of settings to try and standardise, if you will, this that assessment, so there can be comparisons certainly in your go-to programs. What's your comment on that?
Yeah, City of Hope is more a hematology center than an oncology center, as it turns out. We do a lot of bone marrow transplantation. So my colleague who has this aging blood cancers clinic and I've debated what do we do for hematology patients quite a bit. In fact, we have found is the PGA is fine, especially as people are older and more debilitated. Many of our older transplant candidates are, in an odd way, very healthy, except they have a, life-threatening blood disorder. And so we actually have to do more extensive evaluations of them before we invest in transplantation. So instead of a mini cog, which takes, a couple of minutes, we do full MOCAs on them because it's important enough to know the nuanced details of what they're not cognitively capable of. Similarly for their independence, where you have very high thresholds for social support for patients who are getting transplanted, because we cannot have a break in the system of support after the transplant when they're at high risk for infections and have to come to the clinic every 2-3 times a week. So I do think you have to tailor your clinic locally to what your goals are. Right. And hematology is a whole different ballgame in my experience. It does require more intense interventions and assessments in general.
I would agree, tailoring it to the individual, but it's better, I would argue, than not doing it. And I think the work that that CARG has done and ASCO to drive this PGA, it takes the argument about what type of geriatric assessment we would do out of the arguments, but you've been so successful in that. There's a lot of work to be done, but it's a good start. Excellent. Well, Irene's back. It's now 6:29. We've had a fabulous hour of discussion. Thank you so much, William, on this visit to Australia. You're welcome back anytime. Thank you so much for your contributions and meeting everyone here. We are much wiser. And yes, we've got thanks in the chat. So over to you, Irene, for closing comments. Thanks again, William.
Thank you, Christopher, to facilitate the Q&A, and thank you, William, obviously, for such an inspiring and fabulous talk. We learned a lot, obviously, about what you've done globally and particularly in the US. And I also would like to thank my team from the Geriatric Oncology ReViTALISE project and the Care Economy Research Institute, who helped Christopher and I to set up this webinar, and also for everyone, who's joining us tonight. So thank you, and please stay in touch because, I think, there's a lot of work there to be done that, obviously, like what William was saying, we can do together. So thank you. So we have people from San Diego. I know there are some people from Indonesia. There you go, William. So someone from San Diego following you all the way here.
Yeah, I look forward to seeing Blanca when I'm back in Southern California.
There you go.
Thank you for Christopher and Irene and your teams for hosting me. It's been nothing but informative for me as well. Thank you so much.
So thank you and good evening, everyone. Bye.